Okay, hello everybody. My name's Teresa Davidson, and I'm the Executive Director for the Mid-South Liver Alliance. The Mid-South Liver Alliance is a 501c3 that was formed in March of 2021 and is committed to improving, educating, advocating, and supporting children, adults, and families affected by chronic liver disease in the Mid-South states of Tennessee, Alabama, Mississippi, Arkansas, Louisiana, and Kentucky. There are over 100 chronic liver diseases, and we are focusing on the major ones that lead to chronic liver disease. As you can see from our word cloud, we have many diseases we are working on to improve health disparities and access to care for liver patients in our southern states. We hope you will support us as we start developing more educational, medical, professional programs and patient programs for your area. We want to say thank you to members of the Mid-South Liver Alliance Medical Advisory Board for their help in developing this new agency and helping us to determine our educational needs for the Mid-South states. We also acknowledge and thank all the program committee members who took time to develop and work on the strong program, which includes Dr. Alexopoulos, Dr. Shaw, nurse practitioner Jackie Prince, and physician assistant Macy Godman. We also have a big thank you to our board members that are participating in today's events, Chris Oubre and Jeff McElvain. We also would like to thank Global Liver Institute, Genentech, and Exelixis for their support of the Mid-South Liver Alliance. This event will be recorded and placed on YouTube channel for further viewing after the event is over with. I wanted to make sure that everybody knew that was a part of the event in case they have problems with their name coming up in anything. So please make sure that you realize that and you've read and fully understand this waiver in consideration of your acceptance of participation. Okay. And then next, disclosure of relevant financial relationship. Please note this program received commercial support from Genentech and Excel's, and this program is for scientific and education purposes only and will not promote any of the company's products directly or indirectly. The commercial support in no way influenced the planning or content of this program, and no funds from the commercial companies will be paid to the program director, faculty, or others involved in the CME activity. All planners, faculty, and other members in control of educational content are required to disclose all their financial relationships with ineligible companies within the prior 24 months. Jacqueline Prince, our nurse practitioner content reviewer for this educational event, is an advisory board member and speaker for AbbVie and speaker for Gilead Science. Content review confirmed that the content was developed in a fair, balanced manner, free from commercial bias. All of the speakers had no disclosures. The agenda for the evening, we have a lot to cover. I want to thank and introduce Catherine Evans from Global Liver Institute, who's my backup for tonight's event. Kat will talk about some housekeeping news and then pass on the baton to Dr. Alexopoulos for introduction of our speakers.
Thank you very much, Teresa, and thank you for having me here today. Hello, everyone. I just wanted to quickly review a little bit of housekeeping before we get started today. On the bottom center of your screen, you should see a Q&A box. Since this is a Zoom webinar, the audience's audio and video functions will not be on. So please feel free to ask any questions at any time by submitting them through the Q&A box. Our speakers will be addressing them during the Q&A session following their lectures. We will try to get to as many questions as possible, and we welcome your participation, so please do send those in. At this time, we want to explain how you can receive your CME and CEUs. In support of improving patient care, University of Kentucky Healthcare and C Central is jointly accredited by the Accreditation Council for Continuing Medical Education, Accreditation Council for Pharmacy Education, and American Nurses Credentialing Center to provide continuing education for the healthcare team. This live activity is designated for a maximum of 1.25 AMA PRA Category 1 credits and 1.25 nursing contact hours. Please note that the evaluation form must be completed in order to file for those credits. The deadline to claim is going to be December 27th. Information will be discussed at the end of the program, and it will be emailed to you as well after tonight's event. Now I'm going to turn the program back over to Dr. Alexopoulos, who will then introduce each of our speakers, and then we'll start our program.
Hello, hope everybody's well tonight. Thank you very much for the introduction, Teresa. Our first speaker is going to be Dr. Hannah Kim. Dr. Hannah Kim earned her medical degree at Rutgers Robert Wood Johnson Medical School. She completed both her internal medicine residency and chief residency at Vanderbilt University and subsequent training in gastroenterology and hepatology at the University of North Carolina. She also has a Master's of Science in Clinical Research from the UNC Gillings School of Global Public Health. Her clinical practice focuses on patient-centered care for individuals with advanced liver disease. And Dr. Kim is going to be talking to us today about liver cancer, the diagnosis, the risk factors for it, and workup. So thank you very much. Hannah, it's all you.
It's saying I can't share screen.
Teresa, can you help Hannah with sharing the screen?
Okay, can everybody see that now? Okay.
Yes, looks good.
Great. All right, so I'm very grateful for this opportunity to speak with you all tonight about the risk factors for and diagnosis of hepatocellular carcinoma. There are two main objectives for my talk this evening. The first objective is to understand the risk factors for hepatocellular carcinoma, or HCC, and this will help inform who we should be screening or surveilling for HCC. And then number two, to understand how to diagnose hepatocellular carcinoma. And in this portion, I'll be going over different surveillance and diagnostic modalities. Before I get into these objectives, I do want to start with some epidemiology of HCC, just so that we have a better understanding of why this is an important topic. Liver cancer incidence has actually more than tripled since 1980, and according to estimates from 2020, liver cancer is the 6th most commonly newly diagnosed cancer worldwide, with about 900,000 cases per year. It is also the 3rd most common cause of cancer-related mortality worldwide, with an estimated 830,000 deaths per year. And you can see by looking at these rates of incidence and mortality, they're quite close to one another. The incidence of HCC varies greatly by geographic region, with higher rates in darker blue on this map. The incidence of HCC is highest in China, in Southeast Asia, as well as sub-Saharan West Africa. And this is thought to be largely due to chronic hepatitis B infection. When we look at trends of HCC incidence across the globe, there have been substantial decreases in HCC incidence in China, Southeast Asia, and Japan. And this is largely related to hepatitis B vaccinations, as well as hepatitis C treatment. Now, we also have hepatitis C treatment here in North America and the US. However, we are not seeing the same decrease in HCC here, partly due to the hepatitis C epidemic in the 1960s, as well as the rising prevalence of obesity and diabetes, which are associated with metabolic syndrome and the development of NAFLD, or non-alcoholic fatty liver disease. Looking more closely at HCC epidemiology within the United States, we see that this disease peaks around 55 to 74 years of age, with men being diagnosed on average 5 years prior to women at a median age of 60 to 64 years versus 65 to 69 years in women. Not only do men get diagnosed earlier in life, but HCC tends to be a male predominant disease, with men developing HCC 2 to 4 times as often as women. And this is across the various different race and ethnic categories. You can see here there's also racial disparity, with HCC occurring most frequently in patients who are American Indian or Alaska Natives, followed by Hispanics, Asian and Pacific Islanders, non-Hispanic Black individuals, and finally non-Hispanic white individuals. Once someone develops HCC, survival really depends on the stage of HCC at the time of diagnosis. So if somebody presents after they've already developed symptoms such as weight loss, abdominal pain, poor appetite, this is typically reflective of decompensated disease with large tumor burden. And these patients are rarely candidates for any cancer-directed therapies. So they're offered best supportive care or palliative therapy with a 5-year survival ranging somewhere between 0 and 10%. On the other hand, if someone presents in early stages of HCC, then they're more likely to be candidates for the various treatment options such as transplantation, surgical resection, or local regional therapies. And their 5-year survival, while not great, is much better at 50 to 70%. Now, I make these points to really emphasize the fact that it's important to detect HCC early on so that patients have the best chance of survival. And in order to achieve this, we must really understand who's at risk of developing HCC and how to appropriately screen them. So moving on to risk factors for HCC. Cirrhosis is the #1 risk factor, followed by chronic hepatitis B and hepatitis C. Now, hepatitis B and C together account for the majority of worldwide HCC cases. Non-alcoholic fatty liver disease is becoming more important, especially with rising prevalence. And we also know that metabolic syndrome itself, obesity, and diabetes are risk factors for HCC. Excessive alcohol consumption, as well as cigarette smoking within the last 30 years, also increase one's risk for HCC. And studies have shown that after 30 years of cigarette cessation, that increased risk of HCC seems to disappear. And then while it's not as relevant in the US population, aflatoxin exposure from contamination of food crops in some parts of the world, such as Asia, continue to contribute to HCC incidence. As I mentioned, cirrhosis is the strongest risk factor for HCC. 85 to 95% of patients with HCC have cirrhosis. To put this in kind of more easily understood terms, a third of patients with cirrhosis will develop HCC during their lifetime. And the 5-year cumulative risk of developing HCC in patients with cirrhosis widely varies from 5 to 30% and depends on things like the etiology of underlying liver disease, the region a person comes from, the race or ethnicity, and the stage and severity of cirrhosis, with patients who have decompensated cirrhosis and worse portal hypertension being at highest risk. Now, as chronic hepatitis B infection is the main cause of HCC worldwide and accounts for a little over half of cases. In patients with chronic hepatitis B infection, the lifetime risk of developing HCC ranges from 10 to 25%, with an annual incidence of 0.42%. Now, in the setting of chronic hepatitis B, we do know that there are several risk factors that further increase the risk of HCC. And this includes being of male sex, older age, Asian or African race, having a family history of HCC, having higher levels of hepatitis B replication, being infected with genotypes C and D, a longer duration of hepatitis B infection, co-infection with hepatitis C, HIV, or hepatitis delta, as well as environmental exposures such as aflatoxin. The majority of hepatitis B associated HCC cases occur in the setting of underlying cirrhosis, but it's really important to recognize that up to 30% of patients with Hep B related HCC actually do not have cirrhosis. The next risk factor I'll expand upon is chronic hepatitis C infection, and this accounts for about 1/3 of HCC cases globally. About 50% of cases in the US are due to chronic hepatitis C. Having hepatitis C infection increases your risk of developing HCC by 10 to 20-fold, and this increased risk really occurs about 30 years following infection. The mechanism this occurs through is thought to be from repetitive damage, regeneration, and fibrosis of the liver, which also explains why the large majority, approximately 90% of HCC cases, are preceded by cirrhosis. Some risk factors that further increase HCC risk again include male sex, Hispanic ethnicity, being infected with genotype 3 HCV, having a longer duration of infection, being co-infected with hepatitis B or HIV, tobacco use, and heavy alcohol consumption. Now, one of the main factors that actually decreases your risk of HCC in the setting of hepatitis C infection is the ability to achieve sustained virologic response or cure using antiviral therapy. Now, this is supported by a retrospective cohort study of about 22,500 patients treated with direct-acting antivirals across 129 VA hospitals. In this study, they compared patients who had achieved viral cure versus those who did not, and compared the cumulative incidence of HCC, and found that the ability to achieve SVR was associated with a 71% risk reduction in HCC. And this is similar to other publications estimating a risk reduction of about 50 to 80% with cure. One thing to note that was in this study, Patients who had cirrhosis and achieved SVR still did benefit and had lower rates of HCC, but their overall risk of HCC still did remain quite high. And then finally, I'll expand upon non-alcoholic fatty liver disease. NAFLD is becoming more important as a risk factor for HCC, particularly as the prevalence continues to rise. The prevalence is currently estimated to be somewhere between 25 and 30%. And the annual incidence of HCC among these patients is approximately 2.5%. The incidence of NAFLD-related HCC is expected to increase by 122% by 2030. And some risk factors that we know further increase the risk of HCC in the setting of NAFLD are diabetes, as well as being male sex and Hispanic ethnicity. And we see that Hispanic ethnicity being a stronger risk factor in the older population. Some studies actually also have found that up to 20 to 30% of NAFLD-related HCC cases are found in patients in the absence of cirrhosis. And one study that supports this also came out of the VA system, where they looked at 1,500 cases of HCC, and they evaluated underlying etiology of liver disease and the presence or absence of cirrhosis. And you can see here a large proportion of patients with NAFLD did not have cirrhosis, but did develop HCC. Now moving on to screening and surveillance. First of all, we know that screening is important because it leads to improved overall survival. In this SEER Medicare database study of almost 14,000 patients with HCC, they evaluated whether these patients had any HCC screening in the 3 years prior to their diagnosis. One thing to note is that over 50% of the cohort did not have any screening performed, and only 7% underwent what they called consistent screening, which was having screening at least once per year. Screening was associated with an earlier HCC stage at the time of diagnosis. And you can see here in this Kaplan-Meier curve, those who underwent consistent screening had improved survival compared to those who underwent inconsistent screening, defined as screening less than once per year. And both of these groups did better than the group that had not gotten any screening. And that's also reflected here in the 3-year survival rates. So we know screening is good, but who is it that we should be screening? And a little bit of this depends on which guidelines you're reading. Looking at the AASLD recommendations, EASL, and the National Comprehensive Cancer Society, or NCCN, all of these groups recommend that patients with chronic hepatitis B infection should be screened for HCC if they're of African descent, have a family history of HCC, or are Asian men greater than 40 years of age, or Asian females greater than 50 years of age. All of the groups also agree that patients with cirrhosis or stage 4 fibrosis should undergo cancer screening. However, EASL is the only group that recommends universal screening for patients with advanced fibrosis or stage 3 fibrosis. Additionally, the AASLD specifically suggests not screening patients with Child-Pugh class C cirrhosis unless they're on the transplant waiting list. And this is because it's very unlikely that these patients are going to be candidates for cancer-directed therapies. So once we decide to screen someone, how should we screen them and how often? Now, again, these 3 societies on the left-hand side are listed there, and everyone agrees that screening or surveillance should be performed every 6 months. Everyone also agrees that abdominal ultrasound is the screening modality of choice. The AASLD and NCCN also recommend the use of AFP, or alpha-fetoprotein. So if you use a cutoff of 20, AFP has a sensitivity of approximately 60% of diagnosing HCC. And some studies suggest that AFP may detect 6 to 8% of HCC cases that would be missed by ultrasound alone. So the AASLD says to consider checking AFP in conjunction with ultrasound, and the NCCN definitely recommends checking AFP. So ultrasound is the recommended imaging modality for screening, but there are some pitfalls to recognize. It is largely operator dependent. And the studies that have used ultrasound for screening have been predominantly in European or Asian populations, which we know may not reflect the patients we serve here in the US. Ultrasound is also limited by obesity, the presence of steatosis, ascites, and the nodularity of the liver. And it's difficult to differentiate between regenerative or dysplastic nodules versus HCC in cirrhosis. And finally, ultrasound is not very sensitive for early stage HCC. So keeping all of these limitations in mind, some providers actually prefer using multi-phase CT or MRI for screening, particularly if patients have large volume ascites or they're obese with a BMI greater than 35. And at that point, it really becomes an issue as to whether or not insurance will cover it. If we do use cross-sectional imaging for screening or for confirmatory diagnostic testing, these are the typical appearances of HCC on both CT scan and MRI. You can see in the arterial phase, there is hyperenhancement. And then you have some washout in the portal venous phase and further washout during the delayed phases. Comparing these three imaging modalities, you can see that ultrasound performs the worst as far as sensitivity goes at about 59%. And has a positive predictive value of 77%. Contrast enhanced CT and gadolinium enhanced MRI have sensitivities about the mid-70s with positive predictive values around the mid-80s. And regardless of which imaging modality you choose, the sensitivity will increase as tumor size increases. So the cross-sectional images are more sensitive and specific for smaller and earlier stage HCC, but there are some downfalls. The cross-sectional images are much more expensive. If you're doing CT scan, there's real radiation exposure, especially if these patients are getting, CT scans every 6 months. And then there's the risk of contrast toxicity, which limits the use of these contrast-enhanced studies in patients with severe renal dysfunction. So because of these and the fact that it's not considered to be cost-effective, multi-phase CT and MRI are currently recommended to be used as confirmatory or diagnostic tests. So if we screen people with ultrasound and or AFP, I'll just take you through the ASLD diagnostic algorithm. If you do an ultrasound and you find a lesion that's 1 centimeter or more in size, or an AFP greater than 20, then the recommendation is to further evaluate with a multi-phase CT or MRI. The lesions then get categorized based on LIRADS criteria, which you can see here in these various colors. If you have a LIRADS non-categorizable lesion, it is recommended to repeat or perform an alternative diagnostic image in 3 months or less. LIRADS 1 and LIRADS 2 lesions are considered either definitely benign or probably benign respectively, with recommendations to repeat surveillance imaging in 6 months. And for LIRADS 2 lesions, you can consider repeat imaging earlier than 6 months. LIRADS 3 lesions are considered intermediate and intermediate risk for HCC with recommendations to either repeat or perform an alternative diagnostic image in 3 to 6 months. Then we get into LIRADS 4 lesions, which are considered probably HCC. They have some radiographic findings consistent with HCC, but not all of them. And at this point, the recommendation is to have a multidisciplinary discussion to decide next steps. And these conversations usually occur with hepatobiliary surgeons, hepatologists, interventional radiologists, radiologists, and oncologists. And at this point, we're deciding on if we want to repeat imaging or perform alternative imaging within the next 3 months, or if the patient needs to undergo biopsy. Next, we have LIRADS 5 lesions, which are considered to definitely be HCC. And it's important to note that no biopsy is needed if a lesion is called a LIRADS 5. And then we have LIRADS M lesions, which are considered malignant, but not definitely HCC. And these lesions also warrant multidisciplinary discussion. Since we use the LIRADS system to diagnose HCC, one might wonder what the accuracy of these categories is. And a systematic review tried to answer this question by evaluating studies that reported LIRADS categories and confirmed HCC or other malignancy based on pathology, follow-up imaging, or response to treatment. They found that increasing LIRADS categories contained higher proportions or increasing proportions of HCCs. One thing to note is that within the LIRADS M category, more than a third of those lesions ended up being HCC. And another important point is that if you look here within the LIRADS 2 and 3 categories, a not insignificant percentage of these were HCCs, just highlighting the fact that we need to remain vigilant when our patients have these lesions, that they're not lost to follow-up and that we're remembering to order repeat imaging. Once you confirm a diagnosis of HCC, you can stage this according to the Barcelona Clinic Liver Cancer System, and that's what I tend to use for staging. And staging using this system takes into account the size of the cancer, how many cancers there are, and the extent, but it also takes into consideration the severity of the underlying liver disease based on child's Pew class, as well as a patient's ECOG performance status. and which stage a person falls into will affect their treatment options, which we will hear about next. So in conclusion, some take-home points. HCC is a significant cause of morbidity and mortality. All patients with cirrhosis should be screened for HCC every 6 months. High-risk patients with non-cirrhotic hepatitis B infection should also be screened. And as a reminder, these are patients of African and Asian descent, as well as those with a family history of HCC. You might also want to consider HCC screening for patients with stage 3 or advanced fibrosis, particularly in patients who have underlying NAFLD or hepatitis C infection, and also if there are additional risk factors for HCC present, such as advanced age, being of male sex, having metabolic syndrome, obesity and diabetes, or if the patient is also a smoker or consumes alcohol. Ultrasound is currently the recommended screening modality, and adding AFP can increase HCC detection. And multi-phase CT and MRI should be used if ultrasound is of limited quality or as a confirmatory or diagnostic study. And really, again, the goal here is to identify high-risk patients in order to diagnose HCC early on so that these patients can then be treated and have improved survival. And with that, I just want to thank you for your attention. I know we'll have a brief Q&A at the end, but if anyone wants to reach me, there's my email address.
Great, thank you so much for that very informative talk, Dr. Kim, really appreciate it. So we'll have an opportunity to ask Dr. Kim some questions at the end of the speaker presentations. So I'd like to go ahead and introduce the next speaker, our second speaker. Our second speaker is an associate professor of radiology at the University of Kentucky College of Medicine. He specializes in emergency radiology and serves on the carcinoid and neuroendocrine cancer team, the gastrointestinal and colorectal cancer team, the genitourinary and prostate cancer team, as well as the gynecological cancer team, liver cancer team. This Dr. Joseph Owen, who completed his residency at Barnes Jewish Hospital in St. Louis and his fellowship in body imaging at Washington University School of Medicine. And thank you so much, Dr. Owen, for speaking to us today about the radiological aspects and the diagnosis and management of liver cancer. Looking forward to hearing your talk.
All right, thank you all for joining us today. Today I'm going to be discussing non-surgical treatments for hepatocellular carcinoma. So the learning objectives for this talk, at the end, you should be able to describe some of these non-operative procedures that we're going to use to treat HCC, talk about the indications for these different non-operative therapies, and then be familiar and able to describe some of the common complications. I'm going to start with local ablative therapies, of which there's been a number of different types of local ablative therapies used in the liver for treatment of HCC. Microwave ablation and radiofrequency ablation have sort of become the most commonly used forms of ablative therapy in the liver, but cryoablation and percutaneous ethanol ablation are definitely reported in the literature with varying degrees of success and complication rates. When we think about the indications for local ablative therapy, we're really looking at LIRADS 5 lesions, sometimes LIRADS 4 lesions, or biopsy-proven hepatocellular carcinoma. And these should be ideally tumors that are less than 3 centimeters in size. When you have less than 3 centimeters in size, you're going to have a lower rate of marginal recurrence because the size of the ablation cavity that you can achieve is somewhat limited. Now, there is a growing body of literature that supports ablation for larger lesions. So there's growing evidence to support attempting ablation for patients with HCC nodules or masses that are 3 to 5 centimeters. Now, these larger lesions are more difficult to treat because you require a larger ablation cavity. And so they are somewhat location dependent, meaning if they're closer to vital structures like the gallbladder, the IVC, or the portal vein, they may not be amenable to therapy. They're also more user dependent. So you really have to rely on the experience of the person who is going to be performing the procedure. And in some of these instances with these larger tumors, there is a lot of consideration going into a TACE ablation. So we'll talk about chemoembolization shortly, but some people will actually use a combination of a chemoembolization followed by a microwave embolization to treat larger tumors. The idea being that the TACE will shrink the tumor and then you ablate it, and that will reduce the incidence of marginal recurrence. When we think about outcomes, most of the outcome data is really in Child-Pugh A and B. And that goes back to what Dr. Kim was saying about, it may not even be recommended to screen patients with Child-Pugh C because a lot of these therapies may not really be suitable for a patient with Child-C cirrhosis. So there has been some data showing prolonged survival and a similar outcome to resection. Now, that data is certainly not as strong as resection, and I think that there's no question that surgical resection, if a patient is a candidate, or transplant and tumor explant is really the ideal therapy and what provides the best curative therapy. But percutaneous ablation, particularly for nodules that are less than 3 centimeters, we see a lower complication rate than we see with surgical resection, particularly in Child's B patients. We do see a slightly higher incidence of recurrence at 2 years compared to resection. There is a growing body of literature that suggests microwave ablation is really the preferred modality over radiofrequency ablation. With radiofrequency ablation, we have some limitations at treating tumors that are larger than 3 centimeters. And that's because microwave ablation can achieve a wider zone of active heating. There's also, radiofrequency ablation is much more dependent on the vaporization of water. And so there's an insensitivity to charring with microwave ablation. You can get sustained tissue temperatures higher with microwave ablation than radiofrequency ablation. And you can also use multiple different probes to achieve a wider zone of ablation. So overall, microwave ablation is starting to become sort of the favorite modality for HCC ablation in the liver. When we think about our complications, the first thing that's going to be on the mind of the operator or the person performing the procedure is really damage to adjacent structures. So is this nodule near the gallbladder fossa? Is it on the surface of the liver near the colon or some piece of bowel? Is it at the dome of the liver and very close to the pericardium? Because certainly these ablative techniques can cause injury to the adjacent structures. And there are some ways to mitigate that potential injury. So some people will actually inject saline to try and create some separation between the vital structures and the surface of the liver. But that is one of the predominant factors going into the ablative technique and the pre-procedural planning. We definitely see biliary injury and stricture after ablation. Predominantly that injury occurs in sort of peripheral to the ablation cavity. So when you have an ablation, peripheral to that ablation cavity, you may see bile duct dilation or stricture that has occurred due to injury of those more central structures. Bleeding is a concern. It's certainly been seen, really severe bleeding has been seen with cryoablation, less so with microwave ablation and radiofrequency ablation, but it is always a concern. And small perihepatic hematomas post-procedure are very common, but typically are self-limiting. There is a not insignificant incidence of vascular thrombosis, particularly if a lesion is very close to one of the major hepatic veins or a major branch of the portal vein. So that is a consideration and something we will look for, especially if we see worsening liver function after ablation. Fistulas can develop, often passing along the probe track, can result in some communication, and that communication can be between any of the different hollow vascular structures. So the biliary tract, the hepatic arteries, the portal veins, and the hepatic veins. You can see fistula between any of those structures, although it is a relatively rare complication, but well documented. Abscess, also a rare complication, but we do from time to time see superinfection of the ablation cavity occur post-procedure. When the next form of liver-directed therapy is going to be generally referred to as transcatheter tumor therapy. And there are three main therapies that are used in the liver commonly: transarterial radioembolization, chemoembolization, and then bland embolization. Radioembolization is one of the newer techniques and is really gaining a lot of prominence and has a lot of promising data coming out. It is a microvascular embolization technique, so the particles are smaller and they're less oriented to causing ischemia and really more oriented to delivering radioactive particles into specific regions of the liver, hopefully concentrating near the tumor. And they can be used to, again, provide local radiation to the tumor. And they can also be used to perform what is sometimes referred to as a non-operative segmentectomy or hemihepatectomy. So very high doses of radiation can be delivered to a segment of the liver or to a lobe or a hemiliver to cause almost complete fibrosis of that section that the high dose radiation has been delivered. Chemoembolization has been around longer than radioembolization. There are a number of different embolic agents, including particles and glass beads that are impregnated with chemotherapy agents. It is a more combined therapy in that it's a macrovascular technique that is intending to cause local ischemia in addition to providing local chemotherapy. And then bland embolization is a little bit of an older technique. It is really just an ischemic technique, so you're causing local ischemia. And it is not used commonly with hepatocellular carcinoma. It's really found more traction with embolization of neuroendocrine tumor metastasis within the liver. In terms of the indications, there are a number of accepted indications for transcatheter tumor therapy. The first one is really treatment of HCC in non-surgical candidates. So patients who are not going to be a candidate for resection and are not going to be a transplant candidate, these transcatheter therapies should be a primary consideration, especially when there is multifocal disease or nodules or masses that are greater than 3 centimeters. We can also use transcatheter tumor therapies to downstage HCC. So if a patient is outside of Milan criteria, meaning they have more than 3 nodules or masses greater than 3 centimeters or 1 mass greater than 5 centimeters, we can treat those tumors with a transcatheter tumor therapy, hopefully reducing the size of the tumor or the overall tumor burden to get those patients within transplant criteria so that they can get listed and get exception points. We also commonly use transcatheter tumor therapy for patients who are within Milan criteria, who are a transplant candidate and are listed for transplant, to really provide bridging therapy to treat the tumors that are already present and diagnosed and to prevent them from progressing to outside of Milan criteria prior to receiving a liver. So what are the outcomes? And we'll break this down to the different indications. So in non-surgical patients, patients not amenable to therapy, transarterial chemoembolization has been shown to cause improved survival relative to palliative care. And in this case, palliative care really means just best supportive therapy. In terms of comparing radioembolization to chemoembolization, there has been a lot of new data, predominantly coming out of the group at Northwestern, that compares radioembolization to chemoembolization. And they have shown that radioembolization results in an increased time to progression compared to chemoembolization. It causes less toxicity after the procedure. And that's thought to be due to this difference between a microvascular embolic technique and a macrovascular technique. So less ischemia with the radioembolization may cause, less elevated liver enzymes, less post-procedural liver dysfunction. And then there's similar overall survival. They believed that there would be increased overall survival with radioembolization compared to chemoembolization, but in their institute, they actually felt the outcomes were so much better with radioembolization that they really stopped offering chemoembolization to most of their patients, or at least the way they were presenting the option of radioembolization to chemoembolization, most patients were choosing radioembolization. In terms of downstaging for liver transplant, there may be some advantages to chemoembolization over radioembolization. And that's predominantly due to a more rapid response to therapy. So in patients who may be listed for a liver transplant, if the wait time for a liver is less than 6 months in your region, then chemoembolization may be a better option for downstaging. That is because response to chemoembolization can be seen within 1 month or maybe 3 months. So tumor size will decrease, and that may allow patients to get their exception points and move higher on the transplant list. Radioembolization, while it may have a higher overall response, higher event-free and overall survival, they take a much longer time to respond. So after administration of the radioactive particles, you may not see a change in tumor size for 6 months. So it may be 6 to 12 months before you really start to see a substantial decrease in the size of the tumor. And so it may not, if your transplant list is short or less than 6 months, you may want to use chemoembolization over TARE, but the data suggests that TARE has better outcomes if they're not going to receive a liver for 6 to 12 months, which is maybe more similar to certainly the West and East Coast in terms of transplant times. For bridging to transplant, really any of the different options have reasonable and comparable outcomes. There's not a lot of data on bridging for liver transplant. So depending on the tumor size, the extent of the disease, you may use TACE, TARE, ablative techniques, or some combination of them. And the data is not very strong, but it does show that using some form of bridging therapy will increase the time to progression, meaning the patients may stay within Milan criteria for a longer period of time and hopefully remain eligible for a liver longer. And there is also some data that shows increased disease-free survival after transplantation. So patients who do receive a liver and got some sort of bridging therapy have a lower incidence of recurrence after transplantation. In terms of complications, we definitely see more complications with chemoembolization than radioembolization. And some of that stems from this post-embolization syndrome. So that is defined as pain, fever, nausea, or vomiting. It typically occurs within 72 hours of the procedure, but can occur up to 14 days after the procedure. We also can have issues with non-target embolization. So if there are collateral vessels or variant arterial anatomy, you can get non-target embolization of the gallbladder or the stomach or the bowel, and that can result in cholecystitis, gastritis, or enteritis. And then relatively rarely we see abscess formation or superinfection, or even biliary ischemia or injury. And again, that biliary ischemia or injury is due to the bile duct walls really predominantly getting their blood supply from the arteries and not being able to get oxygenation from the portal vein. In terms of radioembolization, much lower incidence of complications. Again, that's thought to be due to less ischemia induced by the radioembolization, but you still certainly have issues with non-target embolization. And because of the concern for non-target embolization, almost all patients are going to undergo a pre-treatment mapping where you are looking for shunting, particularly shunting to the lung. And some patients with a certain degree of shunt fraction to the lung will not be candidates for radioembolization. And if collateral vessels are identified during that pre-treatment mapping, it is recommended that those undergo embolization prior to administration of the radioactive particles. External beam radiation is also an option for patients. It is much less commonly used, but it can be used predominantly as a palliative or salvage therapy. Some people have advocated using it as a bridge to transplant, particularly in patients who may have a small HCC, who may have Child-Pugh cirrhosis and may not tolerate other forms of liver-directed therapy. And there has been some question raised of using it for sort of definitive or curative intent therapy, but there's not a lot of data out there to support that. In terms of outcomes, external beam radiation is generally well tolerated with a low toxicity. Again, it's really only going to provide local control to the region that is targeted, and the data is still very limited. So very few good randomized trials comparing external beam radiation to other forms of liver-directed therapy. In terms of the complications, they are, again, minimal with modern techniques. A more historical concern was radiation-induced liver injury. That radiation-induced liver injury tended to occur really with whole liver radiation, and now with the more precise targeting that is available with external beam radiation, that happens less commonly. Some degree of parenchymal scarring or global confluent fibrosis can occur. Capsular retraction, some bile duct dilation or biliary injury has been reported. This was one case that I saw at WashU where we did have a complication. It was a mass that was located right at the dome of the liver, and it was targeted with external beam radiation. And we can see that there was some injury to the lung and the liver, and they developed a super infection that crossed the diaphragm. And that the kind of the radiation port was in the coronal field and did include some of the lung. And that may be why that complication occurred. Again, relatively rare, but has been reported. In summary, we do have a number of different non-surgical options in our toolbox, and they are, very commonly used and increasing in their availability. They can be used for definitive treatment in patients who are not surgical candidates or transplant candidates. Certainly bridging and downstaging to transplant, there is good data to show that they can be useful in those situations. And then for some degree of palliation in patients who don't have other options. Again, the data is not as good as it is for surgical resection and transplant, but there is a suggestion of an overall survival benefit, a decreased time to progression, and a relatively low complication rate. Overall, radioembolization is really becoming the non-operative standard of care, particularly in patients who are not going to be a transplant candidate. But there is a growing consensus that if somebody is not going to get a liver for 6 months or more, radioembolization should be used for both bridging and downstaging, even in transplant candidates, just because of that lower complication rate and what is a growing body of literature showing improved survival and decreased time to progression compared to TACE. I appreciate your time, and I hope you all found that useful, and I will turn the stage back over for our last speaker.
Thank you, Dr. Owen. That was really informative, and I'm going to have a couple of questions to ask you after our next speaker as well. So I'm looking forward to the Q&A and your participation in that. So our next speaker is going to be Dr. Robert Cannon. Dr. Robert Cannon is a transplant and hepatobiliary surgeon assistant professor in the Division of Transplantation at the University of Alabama. He received his medical degree from Medical College of Georgia, completed his general surgery training at University of Louisville, and also completed his abdominal transplant and hepatobiliary fellowship at UAB, where he's currently on staff. And Dr. Cannon will be talking to us about the surgical management of liver malignancies. Thank you.
All right, so thank you to everyone for joining us tonight. So I'm Robbie Cannon. I'm a surgeon and director of the liver program at UAB, and I'll be talking about surgical management of HCC. There'll be some overlap with the previous two talks, so I'll try and sort of focus more on the surgical aspects, including resection and transplantation. So just brief background, already covering what's been said. It's the 5th most common cancer worldwide, typically associated with cirrhosis, although particularly in older patients or in those with NASH, we can see it without cirrhosis. Most are advanced at presentation, and the 5-year survival is only 15% in all comers, reflecting that typically advanced state at diagnosis. So diagnosis, again, is with screening. Ideally, will be picked up on screening every 6 months. Although the recommendations for ultrasound, again, with the limitations in ultrasound finding early stage cancer, many centers, including our own, will like to at least alternate ultrasound with cross-sectional imaging, or once we start seeing some LR3 or other lesions, we start just looking purely with cross-sectional imaging every 6 months. Again, you see an arterially hyper-enhancing lesion becoming hypodense to the liver, or what we call washing out later. And once again, I want to highlight the diagnosis should be made on imaging findings alone in a cirrhotic liver. We really should not biopsy the vast majority of lesions you suspect to be HCC. If you have an indeterminate lesion less than 2 centimeters, you're going to have a very high false negative rate, and only 14 to 20% will be HCC. So really the only time that we want to pursue a biopsy in the diagnosis of HCC if it's going to change your management. So in our case, the ones typically that we would want to pursue biopsy for, if you have an indeterminate lesion greater than 2 centimeters, oftentimes a very elevated CA19-9 will also lead us to biopsy in many cases. Although the majority of these cases, even with elevated CA19-9, will still be an HCC. There may be mixed tumors, or mixed cholangiocarcinoma and hepatocellular carcinoma. And that'll vastly change management, because if you have a mixed tumor, then that's typically not going to be a good candidate for transplantation, because we've seen the recurrence rates with intrahepatic cholangiocarcinoma are significantly higher after transplant than with HCC. And also, even if outside the setting of transplant, your systemic therapy options are going to be different for HCC versus those with the cholangiocarcinoma component. So this is just a brief overview again of the Barcelona clinic staging system. And what's really sort of important to note about HCC and what makes it really different from almost all other cancers is only part of the staging relies upon tumor characteristics in terms of size and nodal involvement and metastasis, but really the underlying liver function is as, if not more important to a staging of HCC than actual tumor-related characteristics themselves. And it's often the underlying status of liver function that's driving our treatment decisions. But sort of on the left side on the child's on the Barcelona clinic sort of stage A or early stages. Those are sort of what we consider the curative intent treatments. So that would be things like liver transplantation, resection, or in some limited cases, in Barcelona clinic, they still refer to RF. Really the standard has become microwave ablation over RF ablation. And that'll be eligible, probably about 20 to 30% of patients will be eligible for one of these therapies up front. And the remainder, so intermediate stage, that'll be the multinodular patients. Typically TACE has been the standard of care for those. And then in the advanced stage HCC really has been this sorafenib in this slide. However, there's been really great advances within the last year, even for systemic therapy. So it's really an exciting time to be treating HCC because we actually have just much better options for all stages of disease. And we actually have good active systemic therapy regimens available for patients now, really extending survival for patients even in the most advanced stages of disease. So I think, I'll spend a little bit of time on this slide. This is data from Tim Pollock at Ohio State, as well as from the large cancer group in Italy. And this is really the concept of the therapeutic hierarchy for HCC. And this is sort of a much less rigid approach than was prescribed by the Barcelona Clinic group. And this is how I really like to sort of discuss HCC with patients in terms of what their treatment options are for. And what you really want to do is, you want to start with the most effective treatments. That's going to be resection or transplantation. And then you want to consider patients starting at the very top for the most effective possible treatment, and then decide, okay, are they a candidate for this or not? And if they're not, you move down progressively into less and less effective therapies. So you move from transplantation and resection down to ablation, down to intraarterial therapies, systemic therapy, or supportive care. And you really want to make every available effort to try and provide the most effective therapy for each patient, because you can see markedly different expected median survival. So, with liver transplantation, we can see median survivals up to 10 years with a sort of very early stage single HCC. Resection does very well in those settings as well. So you see 100-month median survival. But even when you get to some of these multinodular cases, such as 2 to 3 nodules, total diameters over 5 centimeters, that will typically be described as a Barcelona Clinic intermediate. Under that previous staging system, TACE would have been recommended, but in many cases, some of these patients, if they have good liver function, could be resected. And then, so you're looking at a median survival of 5 years or more in those patients. Ablation can provide a good survival for those who aren't amenable for resection, even in multinodular phases. So you really just want to try and stratify each patient to the most appropriate therapy, aiming for the most aggressive therapy possible in terms of overall survival, taking into account their liver function. So liver transplantation, again, sort of the pluses of liver transplant. Of all treatment modalities for HCC, liver transplantation has the highest overall and disease-free survival, over 70% at 5 years. And really, in most cases, with well-selected patients, the survival is driven not really by the HCC anymore, but by their underlying disease and comorbidity burden. Liver transplantation also has the benefit of addressing the symptoms of end-stage liver disease. Drawbacks for liver transplant: greater upfront mortality than with any of the other modalities. So 6 to 8% 1-year mortality. That's going to sort of vary slightly by center, but really the results for liver transplantation are sort of very tightly clustered at all centers around the country, and ought to have over 90% 1-year survival, if not better, just about everywhere. Patients will require lifelong immunosuppression. And it's not just available off the shelf. If you see a patient in clinic today, you could theoretically have them set up for resection or ablation the next day if you wanted to. But the liver transplant, that can take many more months to years in many cases. And it's getting tougher and tougher to transplant patients with hepatocellular carcinoma. Particularly recent changes in allocation policy have hurt many of the centers in our area in terms of wait time for those with HCC. So we often do need bridging in order to get patients to transplant. So in terms of who we can transplant and who it's a good idea to transplant, and how we achieve such good outcomes with liver transplantation, is all about patient selection. So typically, in order to get standard exception points or priority for transplantation, there's a prescribed set of tumor factors. So you've probably heard of the Milan criteria. So essentially 1 lesion between 2 to 5 centimeters, or 2 to 3 lesions, each less than 3 centimeters, is considered sort of a standard Milan criteria for HCC, and that's the standard indication for transplant. We need to see the AFP of under 1,000. For patients who present with AFP over 1,000, transplant is still an option if they can be downstaged. They can be treated with one of the liver-directed therapies Dr. Owen described, and we can get their AFP to go under 500 and stay that way. Transplant becomes an option. And those for presenting outside of Milan criteria, they're also eligible to be downstaged, particularly those within lesion less than 8 centimeters in diameter, or total lesion diameter. When you add up all the lesions less than 8 centimeters, those patients do very well with downstaging and are eligible for standard exception points. So this is typical what you're going to see of a cirrhotic liver with an HCC where it belongs in a bucket of transplant. And this is sort of the end result. You have a nice new liver free of disease implanted in the patient, normal liver function. You alleviate the complications of portal hypertension and essentially cured their hepatocellular carcinoma. So in terms of downstaging patients to transplant, for those who've initially presented with more advanced disease, this idea was a lot of this data comes from University of California, San Francisco. And when they looked at their downstaging cohort, 41% of their patients received TACE only for downstaging, and most of the rest underwent combination therapy. So usually that's going to be a combination of TACE plus ablation in many cases. They were able to successfully downstage 65% of patients, and 54% ultimately underwent transplantation with a 77% 5-year survival. So again, these are patients who presented with what previously would have been considered advanced disease, and if it simply achieved cure with transplantation following downstaging therapy. There's a meta-analysis was more recently reviewed, so sort of multi-center centers, and 48% are still successfully downstaged. Only 16% had recurrent post-transplant. And really the thing worth taking home from here is multimodal therapy is most successful in achieving downstaging. And really in general, I think multimodal therapy is the best way to go, period. Some data from UCLA showing a complete pathologic response on explant data is most commonly achieved when more than one modality is used for liver-directed therapy. And we're big advocates at our center of either TACE plus ablation or TACE plus radiotherapy or SBRT in order to achieve that. So surgical resection, so that's feasible for patients typically with peripheral lesions and well-compensated cirrhosis or non-cirrhotic patients. If you're going to do a major resection in a cirrhotic, typically we need to see the absence of portal hypertension. That's really what drives our decision on who we can resect or not in many cases. And quick and dirty way to tell this is just to look at their platelet count. If the patient has a normal platelet count in most cases and normal synthetic function, then they're probably, we can be considering resection. And patients can tolerate even up to a right hepatectomy, even in cirrhotics if they're well compensated, depending upon the lesion location, as long as we're able to have an adequate future liver remnant. Usually we'll aim for a 40% future liver remnant in the left over in the patient. And this may require portal vein embolization ahead of time in order to get enough liver after a major resection for the patient to survive. Still not as good of a survival as post-liver transplantation because you still have a cirrhotic liver left behind in most cases, or at least a fibrotic liver, and thus you can have recurrence in the remnant cirrhotic liver, known as the fertile field effect. So really, when we're doing a liver resection for HCC, we really are trying to spare as much parenchyma as possible because of the limited reserve in these patients, which may lead to some creative resections. This is a case we did just a couple of weeks ago. A patient had a 7-centimeter HCC, and it was in the dome of the liver. So we wound up forming a resection of essentially the superior right lobe, segments 7 and 8. So we see that vessel loop on the right-hand side of the screen is around the middle hepatic vein. We've been able to preserve the majority of the inferior right lobe and get a good margin negative resection in a fibrotic patient. In terms of liver-directed therapies, I'll just go briefly over these since Dr. Owens described them in more detail, but typically we have TACE or transarterial chemoembolization, microwave ablation, and then radiotherapies, either Y90 or stereotactic body radiation. Thermal ablation, again, is best for lesions of 3 centimeters or smaller, and we want them away from the major biliary structures. This can be done either percutaneously or with laparoscopy, sort of depending upon the skill of your and the comfort of your IR colleagues and your surgeons. Most patients can be done percutaneously, I think, in busy centers, and it's better for the patient. Chemoembolization, Dr. Owens talked about. And really sort of beyond just the traditional chemoembolization, I think most centers have moved towards drug-eluting beads of chemoembolization away from the old sort of oily taste mixed with doxorubicin. And this has been associated with a higher complete response rate and overall survival compared to conventional TACE. And I think, the outcomes with TACE, a lot of those are really sort of center and operator dependent as well. I think you can get very excellent outcomes with TACE. If your radiologist are willing to sort of take the time and be very super selective in isolating the feeding vessel to get a good embolization for the HCC. And this is our preferred go-to modality for most patients here at UAB over radioembolization because of those results. So this is what you would see in chemoembolization. You've got the feeding vessel selectively catheterized, and then you see this tumor blush, which is sort of the ball of contrast towards the left-hand side of the screen. Then this can be embolized to stasis, depositing the beads containing doxorubicin. So the Y90 or transarterial radioembolization, it's a lot of enthusiasm. A lot of this was pushed by Dr. Shaleem's group at Northwestern. Still finding a role. There's essentially either true believers or not. I think it is definitely a good modality, and there are certainly many centers around that's become the only modality they really use. I hesitate to really call it the evolving standard of care. I think TACE probably still is for these, because I think you can get a really good job with TACE. I think where there's unquestionably a benefit of Y90 over TACE is going to be in those portal thrombosis. That's sort of where we reserve Y90 in our center, because you don't want to be depriving arterial blood supply in a liver that's already got the portal supply compromised. And then there is this concept of what's called a radiation segmentectomy, and that's high dose Y90 to a single segment of the liver in order to induce atrophy, and that can be associated with some very excellent outcomes. And finally, sort of one of the newer treatment modalities on the scene is stereotactic body radiotherapy, or SBRT. And there's been some demonstration of improved survival with SBRT in combination with TACE over TACE alone. And this is how we really like to use SBRT at our center, is in combination with TACE. And we also use it sort of like ablation, but if we have lesions over 3 centimeters, we'll go to SBRT over thermal ablation, again, usually in combination with TACE. In the single center study in Toronto, it's been shown to be equivalent to TACE or RFA, although again, this is a small study. I don't think we can really take too much from that just yet, but it is the least invasive, and in borderline liver function or frail patients, it may be the preferred therapy for those reasons. Now, in terms of systemic therapy, this is where there's probably been the greatest advances in the last few years. So sorafenib, or Nexavar, was the first systemic therapy to demonstrate a real significant survival advantage. And this came out from the SHARP trial, and they saw a 10.7 month median survival versus 7.9 months with supportive therapy. And then regorafenib came along following that, which led to 26-month median survival when following sorafenib. And finally, just within the last year, the combination of Tecentriq and Avastin. So this is essentially a VEGF monoclonal antibody and one of the newer immunotherapies. It went head-to-head against sorafenib in a phase 3 randomized controlled trial. This was published just last year, and median survival in that trial for the combination Bev-Atezo arm was not reached yet, compared to median survival of about 40 to 50 months for sorafenib. So progression-free survival was 6.8 months versus 4.3 months, but again, half the patients had not died in the trial, and that's what we're really caring to look for, is overall survival. So thank you very much for your time, and with that, I'll get my screen back.
Thank you very much, Dr. Cannon. So I think we have the opportunity now to ask some questions of our panelists. And I'd like to start with the first question, which I guess I'd like to hear everybody's response to is, where do we think that the incidence of HCC, primary liver cancer, is going up, down, or staying the same, particularly with advances in the treatment of HCV and ongoing excellent treatment of hepatitis B? Dr. Kim, where do you think this is headed?
Yeah, I think that's a great question. I certainly think that the incidence of HCC with hepatitis B vaccination, universal vaccination of infants and children, as well as ongoing DAA therapy with high rates of SVR will result eventually in decreasing rates of HCC in those patient populations. I think where the concern really lies is the fact that NAFLD is just rising, and it's rapidly increasing in prevalence. And so I worry about the patients who develop HCC who have NAFLD and NASH with advanced fibrosis, even in our non-cirrhotic patients. So, so far we are seeing continued rise in global incidence of HCC, and I think that may continue to be the case.
Do you think that all patients with NAFLD should be screened routinely, or should they undergo a FibroScan first to determine fibrosis staging beforehand? What would you recommend for fatty liver disease?
Yeah, I mean, certainly in your patients with cirrhosis, it's a given to screen all of those patients for HCC. I would recommend, staging these patients with a FibroScan or elastography, whether ultrasound or MR elastography. And if there's the presence of advanced fibrosis, EASL does recommend everyone with advanced fibrosis, regardless of etiology of liver disease, get screened. But particularly in our NASH patients, with some studies suggesting up to 30% of those patients not having cirrhosis going on to develop HCC, I would argue to screen them. Particularly if they have diabetes, obesity, or metabolic syndrome, which would further increase their risk.
Thank you. Dr. Owen, I wanted to pick your brain about Y90 radioablation. And do you see that as a more of a bridge therapy or a curative intent therapy, and what do you guys see as far as a complete pathologic response in these Y90 patients? I don't know if you can answer that.
Yeah, my area of interest, or my research area of interest, is really in advanced HCC. So I've have ongoing projects and done projects in the past on what's referred to as, I guess, infiltrative HCC, and particularly HCC with tumor in vein. And again, a lot of it's not published, but I've got a cohort of about 150 infiltrative HCCs. We've published some of the stuff on using TARE in those patients. And I've seen some pretty amazing outcomes in patients who had tumor in vein, who had disease involving, greater than 50% of their right hemi liver, and they received Y90 and have survived at 5 years disease-free. And again, those are incidental. I mean, that's anecdotal. There's still, I think the data is still building, but at our center, we really have moved with increasing availability of Y90. I think that Y90 for a while, just the procedure, the bureaucracy around actually performing it was harder to get through than doing TACE. But now I think our systems are in place and we can provide Y90 almost as easily as we can provide TACE. And it's really become the main modality that our surgeons and our interventionalists are using to treat HCC. Again, that is not true if it is trying to bridge or downstage to transplant. I think if they're a transplant candidate, TACE is still being used quite regularly. But if it is sort of the end stage therapy, then Y90 is definitely preferred. And I think that's true amongst, so I actually am on the steering committee for LIRADS, and the chair of the RAD Path committee for LIRADS. And I think that there is a growing consensus that Y90 is, the data isn't there, but there is a growing anecdotal consensus that it's outperforming TACE, certainly in advanced disease, not, within Milan criteria, not 1 or 2 lesions. Certainly in those instances, we want to use ablation aggressively. We want to get the patient to receive transplant, or be a transplant candidate. But in these more advanced HCCs, Y90 seems to be getting a growing consensus behind it.
So kind of a follow-up to that, tying in Dr. Cannon and his talk. So I know at our center, we've historically used TACE as a bridge to transplant therapy, and TARE for destination therapy. But we're starting to see a shift in that. Is that something that you guys are also seeing, Dr. Cannon, as far as using radioablation as a bridge to transplantation, just from a cost effectiveness and number of treatments necessary as the waiting times are increasing for patients with HCC?
Yeah, I mean, so for bridge to transplantation, we're still typically using either TACE ablate or TACE plus SBRT in the vast majority of cases. I actually agree anecdotally a lot with Dr. Owen about the advanced HCC, particularly with tumor in vein. Y90 is what we're doing as well. Or if you've just sort of got diffuse sort of HCC all over the liver, because you're not going to be able to selectively target those lesions with a TACE, which is where you get the best outcomes with those. But sort of for the, oligonodular, just a couple of lesions, we're going with TACE in those patients. And ideally, again, we like combination therapy, TACE plus ablation or TACE plus SBRT. And we're doing that for destination therapy as well. And the more advanced HCCs like the tumor in vein or the infiltrative, we're going Y90 as well in combination with systemic.
Great. So Teresa, we have time for one more question.
Yes, we do.
I want to ask one more question that I want to ask, and then there's a question from an audience member. So, a lot of times, like there's kind of an obvious need for a liver transplant for HCC in patients with decompensated cirrhosis. But I have a question for the three panelists. 72-year-old patient with well-compensated cirrhosis, but cirrhosis nonetheless, with a solitary HCC that's located, in the middle of the right lobe. Ablate, resect, or transplant? What would you guys recommend? Dr. Cannon?
Resect if I can. If I can't, we're going to ablate and list for transplant, knowing they may time out if they don't get transplant before they get too old. But, we've got patients living to 80 and 90 now. So I think a 70-year-old trying to transplant them is not beyond the pale, really, but I'd still resect if we could.
Okay. So there's a question from an audience member. The question is, does the stigma around HCV hinder potential treatment options and lead to the increased incidence of liver cancer? I think I would probably direct that to Dr. Kim.
I'm not sure that I'm understanding the question completely. So stigma around hepatitis C hindering potential cancer treatment options?
Do people, because they have hepatitis C and there's a stigma around hepatitis C, the way people contracted it, do you feel that hinders their seeking out care and resulting in HCC that could have been prevented by treating the HCV? That's what I'm assuming is the question.
And I don't have any data to really support this, but there certainly is a lot of stigma around having hepatitis C, and a lot of people that, looking at the qualitative data out there, a lot of people who feel ashamed and don't want to seek care, feel like they're being judged and shunned by society, even the medical community. So I'm sure there are a lot of patients who are not seeking care, whether due to lack of access or personal perception of stigma, who will continue to have ongoing chronic hepatitis C infection and subsequently develop HCC. I don't have the data, I don't know the numbers behind that, but I'm sure that does happen.
Okay. Any other questions from anybody? Okay. Well, I have to say, I thought that this was excellent. I actually really enjoyed listening to all your talks and seeing how different programs approach this. I think there's a lot of commonalities, but there are also some differences. And like Dr. Cannon, I think combination of SBRT with TACE is something that we need to. We haven't really been doing that very much here at Vanderbilt. I think it's something to definitely consider. Dr. Owen, the data for the TARE, it's really great, and really appreciate everybody's participation. Thank you so much. I'm going to hand this back over to Teresa.
Thanks, Dr. Alexopoulos. Well, on behalf, let me see, here we go. On behalf of the Mid-South Liver Alliance Board of Directors, we want to thank all the speakers for their expertise and time in being a part of this event. It was a really great meeting. You guys gave us some really great information. And we want to thank the audience members for submitting questions and for being a part of this inaugural educational program. Just to let you know, the evaluation, if you wanted to take your phone and put it up to the QRQ, you could go on and do the evaluation now. There's also a link, and we will be sending the link out in an email so that you get that and you can fill that out so that you can get your CEs or CMEs. The way to get to claim your credit, all of this information, by the way, is going to be emailed to you. Don't try to take it all down because I don't want you to go crazy. But all of this will be sent to you. I just wanted you to know that we have it all together. You can do it by mobile. You can do it on the website for CE Central. So just letting you know how to best do your claiming for your credit today. I want to thank again the members of the Mid-South Liver Alliance Medical Advisory Board who helped me to kind of start getting this together. I want to thank the committee members for helping us review things and get things going so that you all can get the CMEs and the CEs. And then I want to thank my board members for backing me up as well. And also thank you to Catherine Evans, who is with GLI, for helping us tonight as we did this program. I also want to mention that we are doing a Mid-South Liver Alliance meet and greet. Immediately following this, it's in a different Zoom location. The meeting address is down below the hand as you see. You can hit that before you leave and you can go to that. I will be going to it after I stop us doing this and opening it up. So it'll probably be about 5 minutes before I'm there. But if you go there and you can't get in, don't leave. We'll be there shortly. I'll be there within the next 5 to 10 minutes. We're not going to be very long. We just wanted to kind of meet everybody and kind of do a little talk and thank the people that have supported us. It's really been a great opportunity for us to get out there in the community and to do something that of this stature for everybody. And we're very excited to be out there and to be a part of the liver group out here in the states that we're in. And we hope that you guys will come to the meet and greet so that we can kind of get some ideas from you of what patients need and what you would like to see in the future. So at this point, I'm going to say go on and jump onto that website. And I'm going to close off the meeting now. I'm going to stop sharing my screen and I am going to end the meeting. Thank you again for all you all did. And I'll see you on the other side. Thanks. Bye.